Welcome to Psychoanalysis and You, the official podcast of the American Psychoanalytic Association. I'm your host, Dr. Gail Saltz. The American Psychoanalytic Association is the largest U.S. member organization of professional psychoanalysts, and this podcast will highlight the work of various member analysts and how that work can be of use to you in your day-to-day life. So I'm welcoming today, my guest to Psychoanalysis and You is Megan Rundel. She is a PhD psychoanalyst practicing in Oakland, California, and a graduate of and on the faculty of the Psychoanalytic Institute of Northern California. She's completed a number of certifications in psychedelic-assisted therapy and has been practicing psychedelic-assisted psychoanalysis for 5 years. Additionally, she has been practicing Zen Buddhism for over 30 years and is a teacher with the open source Zen community. So welcome. Thank you so much for joining me today. This is like a super growing zeitgeisty topic. Interestingly, particularly in the field of psychiatry and psychology. And I think a lot of people don't know, and even a lot of psychoanalysts don't know, that this is really made inroads in the field of psychoanalysis. So I'm excited to have you here today. Could you talk a little bit about how you first became interested in the idea of combining psychedelics and psychoanalysis? Let's start with that.
Well, thank you so much for having me, Gail. I'm honored. And I wanted to start by honoring some ancestors, including the many people across time and space in indigenous communities who have used psychedelic medicines all around the world, as well as our psychedelic psychoanalysis pioneers from the 1950s and 60s. You know, many people don't know that in the 50s and 60s, there was extensive use and research on psychedelics within the field of psychoanalysis, done by some pioneers such as Betty Eisner, Sidney Cohen, and Hans Carl Luhner. So they really made the path for those of us who follow.
Was that research that had to do with, at the time, I think, really looking at LSD?
Yes.
And of course, when that became illegal, that sort of ended that research. But this was...
That's right.
Okay. So, and it's been really a long time until this resurgence. So what drew you? Is it the cultural and historical aspect?
Well, so my story is that when I was in college, I did mushrooms with some friends, and it was a really transformative experience for me. It really changed the course of my life. And I would say put me on the path towards both becoming a psychoanalyst and becoming a Zen practitioner. And I had a couple of more experiences as a young person. And, it really kind of showed me a different dimension of experience, which I might now call both awareness of the unconscious as well as to a sort of transcendent reality. And it was very moving and important to me. And then I kind of, went on with my life. I wasn't using psychedelics, in my younger adulthood. But when the research started to come out, as we all started to see maybe 10 years ago about the effectiveness of psychedelic medicines for mental health issues, I was really fascinated. I remembered those experiences and I really believed that they could be, helpful for others. And so I did a series of trainings on psychedelic-assisted psychotherapy, the MAPS training, as well as a few others, and started to use ketamine, which is the currently legal psychedelic agent in my practice.
That's so interesting that you had this personal experience, which of course, you're saying happened in college, was not assisted by a therapist, was just an independent experience. Some people, I have also heard of patients who I was not treating with psychedelics, but who have referred to such an experience just on their own. But I've also sat with patients who've had a bad experience,
Right.
or a neutral experience, let's say, that had
Right.
nothing to do with that. So I guess we'll go on to discuss sort of who's suitable. And really, what I want to start with is, what could this really offer patients that psychoanalysis alone doesn't offer patients? You talk about a transformative experience, which we hope psychoanalysis is for
Yeah.
the patient, and particularly tapping into an unconscious awareness, which is the purpose of psychoanalysis. So what does adding a psychedelic offer a patient that psychoanalysis doesn't already offer a patient?
Yeah. Great question. Thanks. So, the primary agent I work with now is ketamine, and each psychedelic agent works a bit differently. So I'm going to be speaking primarily to using ketamine in this interview because that's what I have the most experience with, even though I'm trained in the use of MDMA and psilocybin, and hope to be able to use them someday in my clinical work when they're legal. So what ketamine offers in particular is a way to help patients who are stuck. Often they have rigid, obsessional, defensive structures. And despite, diligent analytic work, they just have a really hard time going deeper. They often have a hard time accessing affects. And usually I've spent time, using other analytic ways of reaching them, including, relational, conversations, and that it just has felt stalled out. And so psychedelics can offer a way to facilitate a kind of bottom-up processing in which it's a rigid defensive system. It's not eliminated, but it's softened so that bodily sensations, emotions, and primary process material and images can come forward.
So how important is it? You had this experience early on, independent of a therapist being present or guiding you through the experience. How important is it? What is the value? So we're talking about the value to a psychoanalytic patient, maybe who you're saying, particularly who has rigid defenses, particularly who has difficulty accessing what we hope psychoanalysis will help them access, that this may bump them up, if you will, and help them. But
right. Yes.
What does the psychoanalyst bring that is really important? I plenty of people say, well, why don't I just take some mushrooms on my own, or, as you did, or, use some ketamine on my own? What does the training of a psychoanalyst and the presence and the guiding of the psychoanalyst, why is that important?
Yeah, I really strongly believe that psychoanalysts are ideally trained and positioned to be able to facilitate psychedelic experiences. We're really already used to holding an impeccable frame, which adds to the, in the psychedelic world, we talk about the vital importance of set and setting, the mindset of both the journeyer and the therapist or analyst, as well as the importance of a safe setting where there won't be intrusions, where the patient will feel safe and supported and comfortable. And so we already are really good at offering that. We're also really good at holding space and holding the sort of, what Keats called the negative capability, the not knowing, being willing to sit with, often what's emerging in a psychedelic experience is, a venture into the unknown. And we're comfortable with that. We also are very able to work with unconscious processes. And much of what comes up in a facilitated or any psychedelic journey is what we might think of as primary process material. Memories, feelings, images. It's a lot like working with dreams. So in many ways, and we also have a very strong ethical framework and standing that we work from in order to protect our patients from any kind of intrusion or misuse of our trust. So the presence of an analyst is a really good facilitating an environment. And then it's also really helpful because when it's embedded within an analytic process, the patient and the analyst have shared the experience together. And so the integration of the experience, which is a really key part of psychedelic-assisted psychotherapy, is just a part of the analysis, that there will be insights and experiences and feelings that came up in the journey that will, the dyad will probably spend weeks and months and years integrating over time.
Now, psychoanalysts often see patients in treatment 3 times a week, 4 times a week, even 5 times a week. Is this something that you would use in every treatment, or is it something you would only periodically do and then understand and digest? And secondly, are you basically saying this would accelerate a psychoanalysis? I say that because besides the fact that we often see patients multiple times a week, it is a long-term process. It is a long-term treatment. It can span years sometimes, not always. But does this accelerate that time frame?
I believe that it can absolutely accelerate the time frame, in that, especially with people with these really rigid defenses. And I think we've all had the experience of working with somebody where no matter how diligently each person is working, there's just a place that it feels like we can't get to. So it really helps us kind of get to those really, really stuck places. And I think that does absolutely facilitate, and accelerate analysis. It really depends. It's definitely not every day or even every week. And it depends on the person. So I really individually tailor the use of ketamine depending on each person's situation and needs. I'd say it's common to have something like 1 ketamine session a month. And the ketamine, the experience of ketamine is very dose dependent. So I always start with a low dose. And if it seems indicated, work up to a higher dose so that we both get a feel for, navigating that medicine space together. And so we have time to integrate the experience in between through the regular course of the analysis. Some people do something like a series of 4 to 6 ketamine sessions. Some people find it really, really helpful, and we do it something like monthly for some period of time. So it really depends.
Interesting. At the time of this recording, the FDA just recently approved the esketamine, the nasal spray form, for use as an independent agent for people with depression, not necessarily having to also be on medication, but to be used independently. So there's sort of this branching out, I guess I'll say, and increasing research supporting ketamine's use in everything from, actually psychedelic use to some degree, right? But particularly ketamine for PTSD, for trauma experiences. It was for treatment-resistant depression, but now maybe even just clinical major depression in general. It's been looked at in end-of-life anxiety. And as you're alluding to, in different doses, perhaps increasingly in different forms. But I think it's also important for us to discuss that ketamine is a controlled substance. And that is because it has the potential for addiction. It has the potential for abuse. It has the potential for withdrawal. And it has the potential for someone to, because of that, have tolerance, the need for more ketamine to produce the same effect. So as a psychoanalyst, how do you think about that? How do you, would you treat someone who had a past history of addiction with ketamine, who might be at higher risk? Would you, how do you think about dosing and frequency and the concern about abuse or tolerance.
Right, right. Yeah, it's a really important consideration. And so for that reason, among others, I'm really careful in selecting people who I think would be appropriate for this treatment. I would be very hesitant to suggest a ketamine treatment or agree to a ketamine treatment with somebody with a history of a substance abuse disorder for the reasons that you're outlining. And for people who tend to be more sort of impulsive or sort of under controlled, I would move very slowly and be very thoughtful. Those often are not the ideal candidates, although I certainly do know of cases where it can be helpful. I tend to use it myself with people who are a little more kind of rigid or over controlled, and I really carefully screen with a psychiatrist colleague for their medical history, for any history of psychiatric problems or substance abuse problems, and I talk with the patient about it. I really talk with them about the safe use of this medicine.
And so in terms of psychiatric problems, somebody who you have any concerns might, have difficulty with reality testing, anybody who might have real difficulty with boundaries, are those people who you might steer away and say, this isn't the treatment for you?
Absolutely. Yeah, I tend to be very conservative, I would say, in a way, in my assessment and use of ketamine. I know of other clinicians who have sometimes successfully used ketamine with the kinds of patients you're describing, although it feels riskier to me. And so for that reason, I tend to I do not use ketamine with anybody with any kind of psychotic or bipolar process. And for people with a lot of trauma and the disorganizing effects of trauma, I wouldn't say I would never use it, but it would be well into the treatment when they have already learned some of the sort of coping strategies and are able to sort of self-regulate. So, it's certainly not a first line treatment for me for traumatic symptoms.
Have you had patients who've had a bad experience with the ketamine infusion, who've had a bad trip in some way? And how do you deal with that if that is what happens?
So just to be clear, because I am not an MD, I don't use ketamine infusions. The route of administration, there are 3 or 4 main routes of administration with ketamine: IV infusion, intramuscular injection, the Spravato, which is a nasal spray, and then there are oral lozenges. So I use the oral lozenges.
Okay.
And when I start working with somebody with ketamine, we start what we call low and slow. So we start with a low dose, usually a pretty low dose, and it's partly to just see how they respond. And also people are very different in their metabolizing of the medicine. For somebody, 100 milligram lozenge, they might not even feel much. And for other people, they're, into a psychedelic journey. So it's really important to assess that. And so I've had a couple of cases where somebody at that first low dose found the experience unpleasant and didn't want to continue, or it brought something up for them that was, at that time more than that they felt prepared to really be able to handle. So a couple of cases where we put it on hold for quite a while, or where they just decided this isn't for me. And it's good to know that at the low dose. I wouldn't call it a negative experience because the dose was pretty low, but just, good information to know.
Our session.
And then once we...
Yeah, go ahead, sorry.
Once we start to move up to a higher dose, if we do, not everybody does. It's not right for everybody. But, we're always just carefully assessing how are they responding to this. And in that way, I've never had anybody have, a truly negative experience. I mean, sometimes people go through hard things, for sure. Right. That's always the case with psychedelics, is that one needs to face, feelings and memories and so forth that are challenging. And that's very
part of
different
most
from a negative.
psychotherapies,
Yes,
right?
exactly. Right. Yes,
You know, we say it's hard work. It is hard work. And sometimes you have
exactly.
periods of real suffering when you are grappling with something that's difficult.
Yeah.
Do you change session time? You know, we're pretty, psychoanalysts are pretty, 50 minutes is sort of what we do.
Right.
Does that vary?
It does. For a ketamine session, I set aside 3 hours. And the journey time itself is something like about an hour to an hour and a half, hour and 3/4 is the length of the time that a person is within the sort of ketamine journey space. So 3 hours, and I just keep an open time on Friday afternoons for this. It is enough time for us to, meet. We check in, see how they're feeling. Often they will bring something like photographs or special objects to share. And we beforehand, we've been working on setting an intention for the session so that there's a bit of a direction in which we are wanting to go to explore some facet of their experience. And so we review all of that. And then I do the ketamine session on my analytic couch, usually. And depending on the dose, there may be eye shades and music playing. And so they hold the lozenges in their mouth. They have to hold it in their mouth for about 15 minutes. And after that, they swallow. It just becomes like a kind of saliva ball, and they swallow. And at around that time, they start to feel the effects of the ketamine. And that tends to last, like I said, an hour, hour and a half or so. And then there's a little time at the end where they're coming out of the medicine. Often that's a really great time to do wonderful psychotherapeutic work because they're sort of opened up. They've had this often intense and emotional experience. And there's a way that the conversation can be quite beautiful and open and moving at that time. So that's at that time, it's as the sort of tail end of the experience is really a wonderful time to be able to talk with each other.
So how would you describe in psychoanalytic terms what is happening there? What is the effect of the psychedelic in psychoanalytic language?
Yeah, it's a great question. And, since we're all, at the beginning of this work of beginning to understand psychedelics and especially how they might work within the context of psychoanalysis, we're all still learning. And so in the way that I understand it, I draw upon both contemporary neuroscience as well as psychoanalysis to understand the mechanism of action of psychedelics. So psychedelics do tend to help us access unconscious material and primary process by softening, but as I said, not eliminating defensive systems. The psychedelic researcher Robin Carhart Harris, who's at UCSF, theorizes that psychedelics disrupt the default mode network. And that is a group of brain regions that are active when a person is not engaged in a task or who is thinking about themselves. So it's the sort of part of the brain that is responsible for often the kind of looping ruminative sort of and fixed beliefs about self and other and the world. And it is linked to phenomena such as self-assessment, rumination, and just those sort of looping patterns.
Obsessing. I mean,
yes,
the default network is also responsible for imagination and creative thought and innovation and fantasy. Fantasy world, which is, of course, super important when we talk about psychoanalysis. But you're saying also obsessive thinking or obsessive thought.
Exactly. For the many people that we work with who are just stuck in repeating patterns of thinking. And so it's more those sort of rigid structures that we're working with. And when psychedelics are used in a careful clinical setting and combined with an analytic process, they can loosen the rigidity of what we call top-down predictive coding processes. So these processes are experienced subjectively as habitual defensive ways of perceiving and interpreting the world that bind together into like a self-concept and an expectation of others.
Mm-hmm.
So loosening the suppression and repression inculcated by habitual perceptions facilitates this bottom-up flow of internal sensory and affective information that is really crucial to the working through of psychological material, as well as to an enlivened sense of self. So I would say that psychedelics enable rigid judgments to become more malleable, and they can free the mind to perceive self and the world in a new light. And this process facilitates the aims of psychoanalytic treatment because, access to unconscious derivatives allows for the emergence of primary process material, emotions, fantasy life, transference, less hindered by the rigid defensive mechanisms that can really just keep a lid on it. So in this way, both psychedelics and psychoanalysis are really potent facilitators of psychic change. And together they just sort of synergize each other and offer great potential.
So that's fascinating and really helpful to think about it in terms of the neuroscience available in understanding cognition. And in that sense, of course, psychotherapy is about learning something, using your frontal lobe to do so.
Yes.
And which is a top-down approach. We often talk about, right? Psychotherapy is a top-down approach, medication's bottom-up approach, because it tackles deeper brain structure, or includes deeper brain structure, I guess I should say. So is part of what you're saying, now we have access to this deeper brain emotional content via the ketamine or the psychedelic. But you're also saying that our cognitive ability to learn the psychoanalysis, to essentially learn that what is in our deeper brain, and its relevance is enhanced as well.
Right, exactly. Right.
So both.
Yeah. So I think that there can be that, for many people, we can feel that disconnection between the cognition and the affect. And it's like they don't plug in together somehow. So it helps people who often are more obsessional, especially, to, kind of soften that barrier, that contact barrier to the deeper bottom up experience that is more affective and somatic. And so that material can eventually be thought about and learned from.
And so would you say that patients for your type of practice who benefit the most are patients that, psychiatry might define, and psychoanalysts might define as having a character disorder, or, you're saying these are groups that have repetitive patterns of behavior that are essentially maladaptive, and repetitive patterns of thinking that feed those behaviors that are maladaptive. Is that the group, when you've really ascertained that's what we're facing here? We try independently with psychoanalysis or psychodynamic psychotherapy to let their unconscious inform the realization that they're doing those things and why they're doing those things and what they're defending against. But are you saying essentially that group that we normally seek to treat is the group that could most benefit from psychedelic use?
Yes, I'm not sure I would quite call it character disordered, but I would say, people with more rigid defensive systems.
Okay.
And that could be in a more kind of obsessional vein. It sort of can look different ways. Sometimes it looks a little more schizoid or narcissistic, but often, not rising to the level exactly of a full diagnosis.
Okay.
But people who just, are kind of stuck in maladaptive patterns. It's, as I mentioned, it's not usually the first line treatment for people who are more under-regulated or under-controlled.
So you're saying that psychedelics help with regression? Is that?
Well, that is a really great question. I'm glad you asked it because many psychoanalysts tend to think of psychedelics as bringing about a regression. And while it is true that sometimes psychedelics sort of lead us back to a kind of younger self state, not all psychedelic experience is regressive. They also can bring about actually really expansive, non-ordinary states of consciousness that might include strong affect and somatic states and dreamlike images, but they might be more accurately called kind of expansive mystical experiences rather than regressive experiences. And actually, my colleague Karen Peoples and I are currently writing about psychoanalytic paradigms to understand expanded states that happen with psychedelics in psychoanalytic terms, so that we can see them not primarily as regressive, although sometimes they can be, but as progressive and opening new possibilities.
That seems very important in that, a follow-on question might be, we seek out the patient who can regress perhaps in a session, but who can, without tremendous difficulty, reintegrate at the end of the session as they walk out the office, because of course we don't want to send people out feeling super regressed in their day-to-day life. And so I was going to say, is that of concern to help someone to feel very regressed? Can they necessarily sort of reintegrate, at the end of the session? But you're saying that's not necessarily what's happening anyway.
Well, sometimes they feel regressed and sometimes they feel expanded, but either way, they're often in a delicate state at the end of that session. And, so that could be a feeling of regression, but it's also, if somebody has accessed a very kind of joyful, expanded, connected place, that's a really sort of precious place to preserve too. And that's one of the reasons why I do my ketamine sessions on Friday afternoon, so that people have the weekend to integrate. And I really talk with them about taking it easy and taking time, after the session to be quiet, perhaps to meditate or spend time in nature or journal or, listen to music, things that are sort of going to help them move through this sort of different state of awareness that they're in.
So obviously you evaluate a patient for quite a while before you would recommend trying this.
Yes.
And you choose who you think it's best to recommend this to. And so how do you, they've come to see you, you're a psychoanalyst, they think they're doing, psychoanalytic psychotherapy with you for some long period of time. How do you introduce to them the idea that you think this might be beneficial?
Well, so it's a conversation that happens, in a way that's not so different from how I might recommend, say an antidepressant medication. So I would often, and I tend to just keep it very open. I might say something like, I notice that we keep getting stuck in the same place together, and that I know we both worked hard to try to, you know, find a deeper place together, and that it's just really hard.
Mm-hmm.
And so I want to talk about some possible options for deepening our work. I am trained in the use of ketamine, which is a psychedelic agent, as a psychotherapeutic tool, and it is a possibility for us. And just open to what they think. Often people have preconceptions, worries, hopes, and fears, and we just talk about it. Part of it is a much more psychoeducational process than what we usually do in psychoanalysis. I want to give them information. They have a lot of questions. And, it becomes a sort of an analytic object usually for quite a while to talk about before any decisions are made.
Which leads to the impact on transference and of course their reaction and your ability to manage countertransference in the setting. So perhaps you could speak to that. Do you share with them that you have had the experience yourself? How do you handle transference and countertransference in this about ketamine or about psychedelics?
Yeah. Well, if they ask, I'm very transparent that yes, I have used this medicine before. Just like, in order to become an analyst, you have to undergo your own analysis. I think it's really important for anybody working with psychedelic medicine to have their own experience. Mm-hmm. And so I am quite open about that with these patients. And, I let them know too that any psychedelic agent is a kind of a non-specific magnifier. And one of the things that can get magnified is the transference and the countertransference. And so, often it's in a really beneficial way, in that transferences that have been sort of latent and defended against and underground are suddenly available to be spoken to and worked with. And that can be a really wonderful and beautiful thing. And under the influence of ketamine, people tend to feel safe. And it feels safer than usual to be able to speak to things that have not been speakable before. Most of the time, it's just a sort of a lovely and moving experience to be able to go to those places that have been previously warded off. Now, there are times when the transference within the treatment is such that I would be either, really cautious and thoughtful and careful, or perhaps that might preclude the use of ketamine. And in that, I would include any sort of, I'd call it a hot transference, a lot of anger, a very erotic transference, something where there's sort of a unmetabolized, strong transference situation, because I know that it could be magnified in a way that could become too much.
Yes.
So those are cases where I would move really thoughtfully.
Meaning you might not do it, or you have a certain sort of preparation or thought process of how you would manage that when that came to the fore.
I might not do it, and it depends, everything depends, right? If it's a person with whom we have done significant working through it, and it's, this would be what I would hope for, is that we could really talk about it, anticipate. I'm thinking of a case where a patient has an erotic transference, and we do use ketamine together, and we talk about how that feeling gets enhanced with the ketamine. And in many ways, it's useful because he has less shame about being able to speak to it, and it becomes something that's something we can talk about. But I'm always very aware of not wanting to kind of fan the flames in the way that it sort of could become a bonfire that would not be helpful.
Yes.
So it's a delicate line.
So you really need to use a lot of clinical judgment.
One reason why it's really good to be an experienced clinician, to be any kind of psychedelic practitioner. There's a lot of young people these days who want to become a psychedelic therapist right out of whatever graduate school. And I think it's really helpful to have lots of clinical experience in order to be able to navigate the inevitably tricky situations that arise.
So speaking to psychoanalysts, actually very few psychoanalysts use psychedelics at this juncture. I mean,
Mm-hmm.
it is newer, on the horizon.
Mm-hmm.
There are
Yeah.
plenty of psychoanalysts who treat patients with or have them get medication with their psychoanalysis, but not too many using psychedelics, which could be mostly because it's fairly new, but also because, there are unknowns, partially because it's new, and they're uncomfortable. What would you say are important experiences for psychoanalysts to have if they are going to consider doing this in their practice?
So I think the first thing I just want any analyst to know, no matter their level of experience with psychedelics, is that we are actually all really well trained and well positioned to work with patients who are using psychedelics. And many of us these days have patients using psychedelics outside of the session in some context.
Oh.
And we are already so experienced in working with unconscious.
Many of you have the patient that you're recommending it for already uses psychedelics.
Well, at least here in the Bay Area,
right.
I have a lot of patients who use psychedelics in another context. They may be using it recreationally.
Okay.
They may be some people go to a ketamine clinic. They're not using it with me. They may be going to an ayahuasca circle. I mean, there's all kinds or working with a guide. There are many patients who work with psychedelics outside of the treatment context.
So if you're suggesting it to them, but you've already heard they're using it, there are already a fair amount of knowns for them of their experience. You're just saying using it here could allow us to make movement in this treatment specifically.
Exactly. Right.
That's pretty
different. A really different thing.
Right. That's very different from somebody who has never tried a psychedelic to whom you would recommend it.
Yes.
And so do you feel that a psychoanalyst, in order to being offering this treatment, should try it themselves or have had experience with it themselves? Do you feel like that's key?
Yes.
That's important? What else do they need to have done?
Well, a lot of training is needed. So, unfortunately, right now, the training for being a psychedelic therapist is a little bit of a Wild West.
Okay.
So there's not a clearly sort of mapped out route. But there are many good training programs around that train people in the use, of ketamine for sure. Although, unfortunately, most of them are not psychoanalytically oriented. So this is the gap for analysts and analytically oriented therapists, is that the training tends to it's not considering psychoanalytic principles, but you can learn about the medicine and working with it in many ways. So there are ketamine training courses. Many people do other courses in learning to work with, say, MDMA or psilocybin, as I have. And of course, those psilocybin is used in some states like Colorado and Oregon legally. So it's really about training. It's about having one's own experience. It's about getting good consultation, finding like-minded people, and just getting support.
What is the difference? When would you say, okay, I think we should try ketamine versus psilocybin versus MDMA?
So they're each just sort of different in their profile. I mean, right now, ketamine is the only legal option. So that's what we use. MDMA is much, first of all, it's a longer acting agent. And, the main research that's been done has been on its usefulness with PTSD.
Yes.
And I can really see that. I think for people with trauma, and especially relational trauma, that MDMA is a wonderful medicine and will be really helpful when we can use it. So it is more heart opening. It's not a true psychedelic. People tend not to have visions or auditory or visual kinds of hallucinations. But it's more of we call it an empathogen. It opens the heart. It helps people feel and remember and process emotions. And psilocybin is a true psychedelic. It can be really helpful for more kind of making connections, making meaning. It also can help people sort of do emotional processing, but it tends to produce these kind of bigger views of the interconnectedness of things and a kind of more sort of large scale vision of meaning and purpose. So they each are different, and it is one of the growing edges that we are facing as a discipline to really be able to ask this important question: which medicine for which person at what time and how?
And how? I find myself as a psychiatrist and psychoanalyst concerned about misinformation or non-research supported information. Many people who are like, microdosing seems great to me, but there really isn't support from a research perspective for the efficacy of microdosing for many conditions. And so it seems just as important to have the correct information, to take the time to support it, that this really is an efficacious treatment. And isn't doing harm.
And I think it's one of the reasons why I think it's just really helpful for all of us to become really educated about psychedelic medicines, the research behind them, their indications and contraindications, their safety profiles, so that we can understand that and so that we can communicate with patients, many of whom do have misinformation.
Since, as you point out, psychoanalysts are sort of, not as forward in the game, if you will, as psychiatrists and, psychologists who are involved with clinics and hospitals. So, for example, if a psychoanalyst is like, I am interested, what is a reputable, where can they look? You're saying it is important to get the information to train appropriately. Where can they turn to look for that training?
So I'm hesitant to recommend training programs because at this point there are a fair number of them and I'm not familiar with all of them. I can tell you that some of the training that I did that I thought was good, I did a year-long certificate program through CIIS, I'm forgetting what the acronym is for, but it's offered on both coasts. That's a year-long training program in psychedelic-assisted psychotherapy. I also did ketamine training and some other training programs through Fluence, which is a group that is very reputable and offers a bit more psychoanalytic perspective than some of the others. But there are many training programs all around the country and the world. And one just has to do their due diligence and talk with people who have been through it and really understand what exactly they're be training in and what, kind of where that might lead them.
Do you find a growing number of psychotherapists are interested in training? Is that, I don't know if is that there a phenomenon of growth in this area?
Absolutely. There's a huge phenomenon of growth, especially in the sort of younger generation of therapists coming up. But I know a number of psychoanalysts who have trained and are interested in and working in psychedelic-assisted work within psychoanalysis. So we're still a small band, but definitely growing. And, many people who are really we're kind of at the edge of the exploration of many things. It's an exciting place to be, a little risky as, things that are out on the edge are, but also very exciting and I think very promising.
And if a patient is looking to be with someone who can do this kind of treatment, who is experienced and reputable, what would you say to the person who's like, I have interest?
I would say, just to start by talking, if they're a patient already in psychotherapy or psychoanalysis, to start by talking with their own practitioner and to see if that person can my hope is that we'll all become more and more educated, and that many of us, whether we're planning to use these things in our own practices, that we'll become better at being able to make recommendations and referrals and to work collaboratively with other providers. So it's, I wouldn't say there's sort of one thing that I would suggest. It's really about kind of talking to different people and finding options. And
I guess you do have to collaborate somewhat, right? I mean, if
Absolutely.
you're a psychologist, you can't write a prescription for.
No, I collaborate with my prescribing psychiatrist. I have collaborated with guides. I've collaborated with shamans. I've collaborated with ketamine clinics. So there's a lot of, just as we would collaborate in any other way, I think it is really important. And I think psychoanalysts can sometimes feel a little hesitant to, if somebody's working with a guide, for example, that's out, not with you, to talk to the guide.
Yeah.
Just as we would with any other kind of professional.
Absolutely. Well, this is fascinating. Thank you so much for enlightening all of us today about this really interesting and growing and unique intervention that can, I guess, really, you're saying, enhance a psychoanalysis, which still, remains a key, important, vital treatment for many, many people. So thank you so much for sharing all of your
Thank you so
knowledge.
much, Gail. I appreciate it.
Thank you for listening in today. We at the American Psychoanalytic Association hope to introduce you to the many ways psychoanalytic thought affects the world around us, and especially you, through this podcast. We would love to hear your thoughts, questions, and requests. If you haven't already, please subscribe to this podcast on your favorite podcast platform. Follow APsA on Instagram, Facebook, LinkedIn, or X at psychoanalysis_ with the hashtag APsA podcast. And feel free to send a question or comment. You can find more information about the American Psychoanalytic Association by going to www.apsa.org and listen to more episodes and find bios of our guests online at apsa.org/podcast. If you found this episode useful, please share with a friend or colleague, and we will be back next month with another episode of Psychoanalysis and You. I'm Dr. Gail Saltz, and it's been my pleasure to be your host of Psychoanalysis and You. And now for some Freudian quickies. You sent in your questions for an analyst. I grabbed an analyst with an answer. Till next time.
Why do many analysts have an analytic couch? And what are analytic couches like, if we do?
Analytic couches need to be comfortable and create an atmosphere where people feel like they can say whatever they want. People have to be vulnerable when they're in these conversations, and couch allows you to be open.
It's two questions. Why do many analysts have an analytic couch? Analysts have analytic couches for at least three reasons. One is history. Freud had a couch, and we connect ourselves with that symbol of the beginning of analysis. Another one is identity. It sort of feels like you're not quite an analyst unless you have a couch. My first analytic supervisor suggested that I was ambivalent about being an analyst since I couldn't afford a couch yet and didn't have one. But probably the main reason is that it's a very important and useful tool to be able to free one's vision from the analyst. Allows the patient to go more deeply inward and look more clearly at their own internal world without having to gauge it against the analyst's reactions. What are our couches like if we do have couches? Our couches say a lot about us. We think as analysts that we are blank slates. We're not. We are always showing who we are and Our couches are as individual analysts are. Some couches are very classical and draped with rugs like Freud. Some are very modern and clean with absolutely nothing on them except that sort of mid-century style modern. And some are like a living room couch where people can lie down or have family meetings or just be cozy.
Analysts have an analytic couch in order to allow our patients to relax and free associate without having to be burdened by ordinary social obligations, such as eye contact and managing facial expressions and so on. But really, many analysts don't have an analytic couch and work face-to-face. And if we do have an analytic couch, they can come in a variety of different sizes, shapes, colors, and so on. They're just as varied as there are analysts.